Bismillahirrahmanirrahim. Assalamu alaikum. Today our topic of discussion is about Scleritis, its different causes, its clinical manifestation, investigations and possible treatment. These are the corneal photographs of a patient. Here we can see the advanced changes which have happened in a patient because of repeated episodes of Scleritis and prolonged disease. The sclera, the whitish layer over the eyeball, the outermost coat we can say, that has undergone thinning because of repeated inflammation, chronic disease, and due to its thinning, the underlying uveal tissue, by which I mean choroid and ciliary bodies, now they are getting exposed. Yes. So we can say that these are now staphylomas also formed, ciliary body we can say, that is bulging anteriorly. And if we concentrate on the cornea, due to repeated inflammation and all this activity, the white haze is over there which is shown, and that is band keratopathy. Yes. That haze which we can see over there in the cornea in the central, that is band keratopathy. There are some other photographs. Here we can see again band keratopathy, scleral thinning superiorly, and uveal tissue bulging and coming outwards. While if we see the slit lamp in which the slit has been formed over there, we can see that the anterior chamber is shallow, and that is because of the adhesions between the iris and the cornea. So it is not well formed anterior chamber. See this photograph. This photograph is of the same patient, but it was taken 5 years earlier. This is to show how the things start up. And initially we can see a bluish discoloration over there, bluish hue over there. That is because of the changes happening in the sclera, the white outer coat undergoing changes, inflammation and thinning going on, so that we can get some image from the inferiorly also, the impression of the choroid. So this is the photograph which is shown, is basically same patient, but almost 5 years back when the disease was started. These are some other photographs, earlier photographs. Again we can see pupil is round and anterior chamber is well formed. Thinning is of course there, some sclera and bluish tinges coming. While the other slide, it is shown ciliary congestion, scleral and episcleral vessels getting congested, inflamed, red. So one slide is showing also the inflammation in the sclera, episclera. Advanced changes happen because of repeated episodes. Now there is no more congestion, no more inflammation. The episodes have settled down, but in spite of that, the changes which have been done are still over there, prevalent, and we can see all around the eye the greyish appearance under it. Over those greyish, the blood vessels are not congested. Some other photographs of ciliary body staphylomas and scleral thinning, especially occurring over the superior, along the superior limbus, superiorly, and the uveal tissue is bulging out of this. So now we can say that because of repeated inflammation, the sclera is undergoing necrotizing changes. It is melting towards that side, we can say. Some photographs along with scleral changes again showing another angle to see and show how the anterior chamber has become shallower because of the adhesions between the iris and cornea, and there is corneal haze, which later on I showed earlier turned into band keratopathy. So all this is going on in a patient. This scleral thinning is not only affecting the superior part of the limbus, but also temporally. Here we can see localized blood vessels inflamed, congested, and under it again the bluish coloration because of the thinning of the sclera, changes that is happening. We can see things going towards melting, and we can see under it the choroid tissue. So all this is happening not only superiorly but also temporally in the eyeball. See what happened this patient after this repeated episodes of inflammation and scleral thinning, scleral melting, staphylomas being formed, iris adhesions, endothelium getting involved. So the corneal endothelium, here we can see that has been damaged, and the typical mosaic pattern is no more available. So we can say that the cornea is also undergoing decompensation. The ultrasounds, B scan of the patients, very helpful in these patients to give us information about sclera. So in this B scan we can see that when it was done, the thickness of sclera was 0.28 millimeter inferiorly, but where I showed the staphylomas being formed, here at these locations the thinning of the sclera is 0.18 millimeter. So that's one thing very much evident over there on the B scan. And second thing is, in these blue squares and blue boxes, I have shown the accumulation of fluids. Usually in posterior scleritis, it happens that fluid accumulates around the optic nerve also, and posterior to episclera. That's I'm talking about posteriorly, and which usually we call the T sign over there in the posterior scleritis. But here you can see that so much fluid is have been accumulated over there, that is shown in the blue boxes. UBM cuts to show where the thinning, the measurement was done. As I mentioned, the place where was superiorly staphyloma, there 0.18 is the thinning, while other is 0.28. So this is the classical place where the measurement was done to the UBM cuts. Two other photographs, one is the UBM and the other is B scan. As we have seen earlier in the photographs, that the anterior chamber is very shallow because of the adhesions formed between iris and the cornea. So this UBM is just confirming it. Then the blue arrows are showing how the iris is bulging forward, touching the cornea, and the anterior chamber angle is almost closed. So this is just to confirm it. And the other is the B scan. B scan, again we can see that along the optic nerve over there, extensive fluids are present over there. Yes, and there is the retinochoroidal layer thickening, especially if we concentrate posteriorly where the red brackets have been formed. So all these things are happening in this patient of scleritis, which are shown in the B scan and the UBM. Basically, scleritis, we call it, is an inflammation of the sclera, the outermost coat, the white layer outside. When this layer gets inflamed, it is scleritis. When it is anterior to the insertions of the muscles of the eyeball, recti muscles, we call it anterior. Posterior, if it is, we call it posterior. Anterior may be diffuse, nodular. Posterior, when it is involved, it may involve the vasculitis element over there also. Sometimes it is necrotizing, and necrotizing is quite painful over there. So this is basically inflammation going on. And in all types of scleritis, there is scleral edema. And along with scleral edema, there is, if you go at the molecular levels, T cells, B cells, plasma cells, all they take part in it. And granulomatous reaction happens over there. So all this activity is going on at molecular level, which is causing all these changes. The most serious is the scleromalacia perforans, which is not very painful, but high chances of losing the eyeball. So these are the basic, we can say, the pathology going on over there. But usually anterior ones are quite tender, painful scleritis over there. Talk about the clinical presentation. As I mentioned, these patients usually present with dull aching pain. The eye is red, inflamed for many weeks. They have undergone different treatments, but things are not settling down. If you examine them on the slit lamp and put 2.5% phenylephrine, the superficial vessels of the conjunctiva, they will blanch, but the underlying deep scleral vessels, they will remain inflamed. They will be in crisscross pattern adhering to the sclera, red and inflamed. Along with that, sometimes this pain radiates towards scalp, ear, or the jaw. We should go for the blood works for these patients. Very important to do the blood works. The reason is, when we are ordering blood works, we should keep his history, medical history in the mind. Very important. And we should do complete blood count, ESR, C-reactive proteins, rheumatoid arthritis patients, R effector, anti-neutrophilic cytoplasmic antibodies. We should keep polyarthritis nodosa, Wegener's granulomatosis. All these things should be in our mind, but the thing is, when we are ordering the blood works, we should keep his medical history in the mind. Very important. Because the eye is a part of human body. It is not a separate entity. It is just a reflection of what is happening in the whole body. It shows that one. So it will be very good if we go in coordination with the medical specialists who are treating his autoimmune diseases. It will be very good. Syphilis profile should also be done in these patients. So all these things help us to reach a diagnosis. But usually the clinical judgment and clinical and the ultrasound findings tell us the whole story, what's going on in the eyeball. When we talk about the management, the steroids have a role in the management, and they can be given as a pulse therapy, methylprednisolone. Yes, methylprednisolone can be given IV infusions, but these things cannot be given for longer time because of their other complications. So mycophenolate mofetil is a very good option to replace the steroids. Along with it, methotrexate is another option in rheumatoid arthritis patients. And tumor necrosis factor alpha inhibitors, that's I'm talking about infliximab. It has also a great role in the management of autoimmune related scleral thinning, scleritis. So all these immunomodulators have their role in the treatment and the management of the scleritis. But as I mentioned, when we are giving the immunomodulators, we should keep an eye always, and we should be vigilant about the possible systemic side effects of these medicines. These patients, as I mentioned, undergo scleral thinning, and the uveal tissue is coming out, and there is staphylomas formation, repeated episodes going on. So usually things remain like these in these patients, and they don't need any surgical intervention. Medical intervention is sufficient to control the episodes and the disease. But sometimes the thinning is so much aggressive and the damage is so much that there is exposure of the intraocular contents. So at that location, at that position, we have to put scleral graft, scleral patch, pericardium patch over there. We can use fascia lata, whatever. We have to close and secure that place if that happens. The second thing is these patients also, because eyeball is a spherical structure, so if such changes are happening, it is understandable that there will be refractive errors and astigmatism, cataract inflammation going on. These patients may develop cataract, but there is no urgency. The inflammation must be settled down, and once the inflammation is settled down for 3-4 months like this, then it can be considered to go for any cataract surgery intervention. And all these modalities are on the table, like if the cornea is involved at any stage, keratoplasty can be done. So these are the basic surgical options which can be tried if required. So that was our topic of discussion today about the scleritis. So how sometimes it can be damaging and challenging, and it takes a long course to manage this one. So I hope my today's presentation will be beneficial to my respected and honorable audience in their clinical practice. I want to thank them for their attendance and attention. Thank you.